Hello. Hi, everyone. Good morning, good afternoon, good evening. Thanks to all of you for joining us today. On behalf of the organizing team, we're very happy to welcome you to this webinar, which is a part of our work on the leadership and governance building block for the small and sick newborn care implementation toolkit. My name is Gaurav Sharma, and I'm the MNCH lead for USAID's Momentum Private Healthcare Delivery Project for Jhpiego, based in Washington, DC, and Professor Tim Powell-Jackson at the London School of Hygiene, and I co-lead this building block for the NEST 360 Small and Sick Newborn Implementation Toolkit. Next slide. So as we all know, care for small and sick neonates and post-discharge follow-up is an important priority to ensure that all newborns are able to survive and thrive. This is an ambitious agenda that requires high levels of political commitment and management and leadership at all levels, from the national, subnational levels to neonatal wards at hospitals. The leadership and governance building block for small and sick newborn is comprised of several sub-themes, as you can see in this graphic here, including stakeholder and community. So leadership and governance is one of the building blocks, and leadership and governance building block comprises of several sub-themes, which includes stakeholder and community engagement, leaders and champions, development of plans, policies, standards, and guidelines, hospital management, and data for accountability. So this seminar will only focus on one of those components, which is hospital management and how that relates to quality of care. Although it is generally thought that management practices influence quality of care at hospitals, actual empirical or research evidence examining this relationship is limited, probably because management is really hard to measure quantitatively, and methodological advances have been recent. There is limited evidence to support these claims, especially from low and middle income countries. And as you all know, hospitals are also the most important and the most expensive, resource-intensive, and politically sensitive components of the health system. So management practices at hospitals are seem particularly important. And regardless of the country setting or whether it's the private sector, public sector, faith-based organization, the good management practices seem to be universal. And today we hope to explore some of these things with you. And we will hear about the importance of management and leadership from speakers in London, in India, Malawi, and in Indonesia. And they will talk about their work and experiences in this area. So maybe if we can go to the agenda slide. So in terms of the agenda, we will hear first from Professor Tim Powell-Jackson, who's a professor of health economics at the Department of Global Health and Development at the London School of Hygiene and Tropical Medicine. And Tim has been a real academic leader and champion for MNCH over the past 2 decades, publishing several important papers, and has also contributed to a lot of global initiatives such as the WHO UNICEF Lancet Commission on a Future for Our World's Children, Countdown to 2030, and others. And today, Tim will unpack the concept of hospital management a little more and share some brief findings on what the global literature says about hospital management and quality of care. And then we will move on to country experiences on leadership and governance as it relates to small and sick newborn care. From India, we will hear from Professor Ashok Deorari, who I'm sure many of you know, and who was until recently the head of department for Pediatrics and at the WHO Collaborating Center for Newborn Health at the All India Institute of Medical Sciences. And Professor Deorari has probably trained thousands of students in India and across the world in pediatrics and neonatology. And, ever since I've known him and over the past 3 decades, he has been a real champion for newborn health, pioneering several learning apps before learning apps were in vogue, and also for his work on quality of care, especially quality improvement work, such as the work with POCI in Southeast Asia. After Ashok, we will then hear from my colleague, Dr. Pancho Kaslam, who is the Senior Quality of Care Advisor for the Momentum projects implemented by Jhpiego in Indonesia. And Pancho is an obstetrician and a public health specialist by background. And he has deep experience in this area and has worked with the government of Indonesia, the USAID Indonesia, for the past 2 decades, and been involved in a lot of pioneering work under IMAS, under all of the USAID projects that have happened there. And he has also worked in several countries in Southeast Asia in technical advisory roles. Next, we will hear from Lucky Mangwiro, who's the study coordinator for the NEST 360 program in Malawi, and she's a nurse midwife who's leading the entire NEST study. So thank you, Lucky, for joining us. And then we will hopefully have about 15 minutes for Q&A at the end. And please use the Q&A box to put in any chats, and we will try to answer them as we go along, or bring them out in the panel discussion at the end. So with that, let me turn it over to Tim to take us through his presentation on what the global literature tells us about management, and does it matter for quality of care. Over to you, Tim.
Thanks, Gaurav. So my name is Tim Powell-Jackson. I'm at the London School of Hygiene and Tropical Medicine. I'm going to speak very briefly, just for 5 minutes or so, just to provide a bit of framing and a bit of context that's hopefully useful before we get into the country discussions. So next slide, please. So this idea of hospital management, you'll find all sorts of definitions out there. It's really hard to pin down. And so I don't necessarily want to say that this is the perfect definition of what management means, but it's something that's quite often used. So it's the process of achieving predetermined objectives through human, financial, and technical resources. And within a hospital, it often encompasses this idea of governance. Sometimes it covers this idea of leadership, but people sometimes also like to separate out leadership from management itself. But today we're focusing on this idea of hospital management, hospital governance, and leadership. Next slide, please. And so just to give that a bit more meaning, it's quite useful to think of management and the different domains of management. So on the left here, this is quite a common framework that's used in terms of health system management competencies. And I think many of these domains will be pretty familiar to you. For example, things like human resource management, financial management, operations management. So at the sort of shop floor, clinical level, governance and leadership, community engagement, political analysis, and dialogue. And then on the right, in some work in Malawi, where we're actually measuring hospital management, we use that framework on the left just to create some domains more at the hospital management level. And again, I hope these are pretty familiar ideas for those of you who either work at the policy level or work in hospitals, these kind of areas of management. So as I said, you've got operations, which is really at what you might call the shop floor or clinical level of activity, HR management, target setting, monitoring of activities, and then financial management and quality of care governance. This may not be all encompassing, but I hope it does give some flavor of what we're what we're talking about when we talk about hospital management. Next slide, please. And then finally, I've just got 2 slides from a sort of global literature review we've been doing, where we're trying to look at the evidence on the link between hospital management and quality of care. So is there a relationship between how well a hospital is managed and quality of care? Now, this isn't specific to newborn care. This is specific to all aspects of quality of care. And what we did was we screened over 9,000 studies, and we ended up including 21 studies, of which they conducted 112 analyses. So in high-income countries, the high-income countries studies, of which there were 58 analyses, so just under half of those, they found significant associations or correlations between hospital management and quality of care, and slightly higher in low and middle income countries. So there's definitely some evidence out there that there is a relationship between hospital management and quality of care. Next slide, please. And then we've taken the same list of analyses, these 112 analyses, and we've separated them out into different types of outcome in terms of quality of care. So we've looked at what is the relationship between management and structural quality of care, so the availability of inputs, processes of care, so that's kind of clinical quality, and then final health outcomes or patient satisfaction. Now, the number of analyses is varying across these different outcomes, but there is quite a clear trend that, there's a really, I would say, good body of evidence showing an association between management and structural quality. And then as you go to processes of care, the number of significant associations is about 54%, so about half of the studies. And then when you come to health outcomes, the number of associations dips below 40, around 40%. And that kind of makes sense. It's probably harder to establish that link with final patient outcomes, health outcomes. But there is certainly still a good body of evidence suggesting that there is a link. So I'm not going to talk any further because this is just to provide an overall framing, and we really want to delve into the country level experiences. So I'm going to hand over to Ashok Deorari, former head and professor at AIMS. And thank you very much, Ashok. Look forward to hearing from you.
Thank you, Gaurav, Jackson, Joylon, for giving me the opportunity for joining in this webinar. May I have the first slide, please? I bring greetings from a new institution, which is called as Himalayan Institute of Medical Sciences, Swami Rama Institute, and this is a university, Swami Rama Institute of Health Sciences in Dehradun, which is in Uttarakhand. And previously, as Gaurav said, I worked at AIMS, New Delhi, WHO Collaborating Center. Next slide. I am going to cover very briefly how governance and leadership is embedded into quality of care for small and sick newborn babies in our country. Next slide. So in India, small and sick newborn baby is a part of facility-based newborn care. The federal government, which is also called the central government, has developed the policies, the protocols, what the infrastructure has to be, how much manpower has to be there. There are guidelines for the equipments to be there, SOPs, standard treatment workflows, and then there are quality assurance criteria which are under Muskan, which is one of the quality assurance and accreditation process for the special care newborn units, which are more than 100 in the country. And then they also have an online system of collecting various indicators which are collated at the national level for comparison and then for improvement. Next slide. So if we are talking of governance which has to be done for kangaroo mother care, adoption in the country at the level of the facility. We know the central government has already developed the policy. They have the guidelines which are there. They have also laid down the structure, what a small kangaroo mother care unit has to be, how many bedded, which has to be adjacent to the SNCUs or the postnatal ward. And they have the central SOPs and standard treatment workflows, which have to be there. And at the level of the state, there is a framework for the implementation. There is a nodal person in the state who works in the health department. And then there is a district data collection on what is the coverage of kangaroo mother care for the eligible babies, which is happening, and for the duration for which the kangaroo mother care is being practiced for low birth weight babies. And at the level of the facility, again, there are lots of newborn champions who are able to make sure that the newborn babies who are sick and small get high quality care. They collect the data. And in many places, we have the quality improvement teams which have been trained by national trainers so that they can improve in the implementation of best practices in these small care newborn units. These are called as the SNCUs. Next slide. So I am giving you just a shot of the data which is collected, which is online data system. And then with a click of button, what you can do is you can have collation of total data for the country and then one state where you are standing, and then you can have a comparison which is the best state. So this one shows the follow-up after discharge of from the facility-based newborn care unit. The patients who are coming for follow-up at the age of 6 weeks is pretty low at 14% in the entire country collation, and in a state which is doing better, it is 33%, and then in a state which is in Northeast, this is from a data for a period of 6 months. So that indicator can be seen on a mobile phone or on a computer, just with a click of button. And then for antibiotic usage, you can have a data, you can have usage of data for mortality, which is happening for babies below 2.5, where that particular district is standing, where that state is standing as compared to the other states. You can do a comparison also. And then looking at that data, there is an opportunity, low-hanging opportunities on which improvement can be done, and that can be done with the help of quality improvement, process improvement. Like for early initiation of breastfeeding, the rates vary from 40 to 65% during first 1 hour. The KMC coverage in the country is average is like less than 25%. Survival for 1800 below 1800 gram is 40 to 50%. And then for the number of SNCUs which are there in the state, you can have the comparison. Next slide. In addition to FBNC, what is happening in the country is with the help of the professional organization, which is National Neonatal Forum of India and Indian Association of Newborn Nursing, WHO Collaborating Center, there is a value addition that we are training people with a blended learning tool for facility-based care for preterm babies. And luckily, this whole package is developed with the help of Queen Elizabeth Diamond Jubilee Trust, which gave us the funding, and Claire Gilbert from London School was partner to it. In addition to PGI Chandigarh, and we had the Public Health Foundation of India, which was the main source which oversaw the monitoring of the entire project. And in this, the teaching learning is on the web, which is for learning preterm care. It is on an app on a mobile phone, and large number of nurses and doctors are getting trained even with the help of a app, which is the Telegram app on mobile phone. So this is a supplementation of FBNC training, and the FBNC training is not only didactic, it is with skill learning, with observership in a unit, which is a good unit, which is a mentoring unit for that SNCUs. Next one. So there is in the health system, there is a district level planning which is there. There are regional nodal centers which are there. And then we have the state resource centers. These are in the medical colleges or private institutions, and each medical college mentors 4 to 6 SNCUs or a private institution mentors. And they are linked with the IT, and they do the mentoring, supervision, training, including the quality improvement. This all happens with the support from the central government, which is called as the National Health Mission, and with the help of the partners which are working in that particular state. And then for making that health system is working in a right manner, there has to be adequate manpower, infrastructure, supply chain, data has to be collected, you need resources, and there has to be accountability and governance. The thing which is lacking is, which we find the bottleneck is for the manpower and for good quality data collection in most of the places. Next one. And then for bringing accountability, there are regular updates and feedbacks. There are rewards which are given for good units, and even the resources which are given is based on how the units are performing, which is by on-site evaluation and whether they are collecting data or not. And then the federal central funding is nearly 60%, while the state funds 40% for the SNCUs to run of the amount of money which is required to run them. Next one. There are few states in the country which have already reached single-digit NMR, like Tamil Nadu, Kerala. And there in Tamil Nadu, what happens is policies which are made by the state government, they don't change. Even with the change of political leadership, the same policy is continued. And then there is an easy access, free healthcare in the state, and functional healthcare system, which is manned by competent healthcare professionals 24/7. Even the maternal units, the labor room, and even the newborn units. And then clinical audits for near miss and deaths in the facilities at the level of the facility are happening, and at the level of state also happen. So good governance, they already reached the single digit NMR, and the states which are lagging behind need to learn from them what that led to this lower NMR in the country. Next one. Problem which we have seen with the leaders and managers while we work is they think if NMR has declined, they are unaware that this is a time to focus on quality of care for small and sick babies. They think because NMR has declined, India has a NMR which is like 23 per 1,000 live births. So if in their state it is below 20, they think we have made a lot of progress without realizing now the focus has to be on small and sick newborn baby. The other thing which they often confuse is they confuse quality improvement, which is a process improvement, with quality assurance, which is for structure and SOPs. They are not ready to believe that quality issues exist in their health facilities and everything is good. So they overlook the problems, while the frontline worker, the doctors and nurses know that there are problems which are existing in healthcare facilities which need improvement. So there has to be a paradigm shift in the mindset which is needed for the leaders and managers who are responsible. And these leaders and managers often are not non-medical, they are bureaucrats. Next one. So we need, if we have to make sure that there has to be a good governance and better quality of care, which has to be delivered for small and sick newborn babies, and we want to avoid stillbirths, we need to have a collaboration between the professional organizations like the Federation of Obstetrics, Gynecology Society of India, National Neonatal Forum of India, Indian Academy of Pediatrics, and the various stakeholders like the Government of India, which is the federal government, National Health Mission, the states, partners, and the NGOs. And then we need that Ministry of Health, Family Welfare, medical colleges, National Health Mission in the state, and the Medical Education Department, the National Health Authority, which implements Ayushman Bharat, which is a free insurance for patients who are poor in the country below the poverty line, and then partners in the field and private. Everyone has to work together if we have to make sure that we are able to give good quality care for small and sick newborn babies. And for this, what we need is coordination, cooperation, communication, and convergence, and then deliver the best quality of care. Thank you. So may I ask Dr. Kaslam from Indonesia to take over from me? Thank you.
Thank you very much, Professor Ashok. Thank you for this opportunity. Before proceed to the share experience, a brief country profile is shown in the slide. Slide, please. Yeah, briefly, Republic Indonesia, as you see, is in the Southeast Asia and Oceania between the Indian and Pacific Oceans. Borders with Papua New Guinea, East Timor, and eastern part of Malaysia, as well maritime border with Singapore, Vietnam, Thailand, the Philippines, Australia, Palau, and India, Andaman and Nicobar Islands. With 17,000 islands in the world's largest island country, the largest archipelagic state with almost 2 million square kilometers of area, and the world's fourth most populous country with over 279 million people. So with the 37 provinces and the country capital Jakarta is the world's second most populous urban area. See how the complex of this country in our place setting with the decentralization. Next slide, please. I would start the experience based on the principle of the good care and respectful maternity care. Our focus is on the maternal and neonatal health services. The maternal and neonatal health services cannot be separated. They are interrelated, vary each other. The hospital management should well first on hospital regulation, also national and local government policy. A lot of policy and political involvement in this management of the health facility in Indonesia. There are 4 points that I would like to share our experience here. As we see in the left side, number 1 is what has Indonesia done to strengthen clinical governance and hospital management for MNH focus on what has been done after the 2017 MNH Evidence Summit. Indonesia has made tremendous progress to improve maternal and neonatal mortality over the past few decades. There has been considerable progress in increasing facility-based deliveries and steady declines in maternal neonatal mortality during this time. MNH Evidence Summit held in 2017, supported by USAID, which successfully highlighted some of the long-standing challenges on improving maternal and neonatal health. Newborn health is still an unfinished agenda with still many preventable newborn deaths happening at the facilities. The Evidence Summit highlighted that we need to work on improved health system management, clinical governance, strengthen referral process, and improve accountability to provide high quality care, and work to improve for reliable information system on cause of death and modifiable factors for maternal and perinatal deaths. Following the Evidence Summit, Indonesia embarked upon work to strengthen advocacy for newborn health. There are known charismatic leaders and champions for newborn health in the country, which prior to the Evidence Summit had developed Indonesian Newborn Action Plan, or INAP, in 2015. The INAP focused on strengthening the health system for emergency response and operationalize referrals such as basic emergency obstetric neonatal care and comprehensive emergency obstetric neonatal care. Following recommendation in Evidence Summit to the Minister of Health of Indonesia, a National Technical Working Group for Acceleration of Maternal and Newborn Mortality Reduction had developed, which signal high-level political commitment. Demand creation through empowering communities for quality newborn health services has been done. Also, effort to support governance at the local level by working with the range of local stakeholders, such as working group, they call it POKJA at the district level. These working groups are crucial and very effective to bring about change since they influence many factors beyond the direct provision of care and have influence on funding, resources, and provision of services. There has also been a lot of work to ensure system-wide accountability across the health system and also accountability at hospitals and primary care facilities. We have also been working to strengthen linkages across all levels of the health system to facilitate supportive supervision, hospital mentoring, and create effective and efficient referral system. This also includes valid and reliable data with strong information system at the point of care and also at the facility, district, province, and national levels, including referral information system and system for monitoring quality of care. And we can see another box in the question of sharing our experience on how poor management, governance, accountability constrains good quality newborn care at the public and the private sector facilities in highly centralized health system like Indonesia. In Indonesia, the private sector is a major provider for maternal and neonatal health services. Like the public sector, the private sector struggles with suboptimal maternal and newborn health capacity, lack of institutional readiness, poor service, poor management, and insufficient quality improvement process. Persistent shortage and unequal distribution of human resource for health, insufficient incentive, and problem with training, licensing, and certification dampen private providers' commitment to invest in measures to improve the quality of services. Limited engagement of the private sector is due to suboptimal policies, incentives, and regulation to support their participation and ensure implementation of quality improvement processes. Because of decentralization and poor integration between public and private health system in Indonesia, enforcement of clinical governance is managed by many different stakeholders. These issues are especially prominent in issues of data management and referral system, which often fail to collect or omit data from the private sector. Delay and poor quality MNS referrals, especially originating within the private sector, have exacerbated this problem. Although care seeking for neonatal illnesses is generally sought from private sector midwives, this is very problematic because many private practices are not accredited, and there are significant gaps in oversight, certification, and accountability, with no one fully responsible for clinical supervision that ensures the quality of service delivery. Also specific to small and sick newborn care, midwife, especially in the private sector, may see very few cases and may not have the opportunity to receive updated knowledge or have the opportunity to repeat practice their clinical skill. Compliance to the existing standard of newborn care, including reducing harmful or unnecessary practices, is poor, and existing structural barriers at the health facility are not ideal to promote zero separation of mother and babies. There are also important challenges with regard to management related to availability of infrastructure and equipment and human resources. In some places, we find that many neonates that were referred during weekend public holiday have to face many delays at the facilities due to limited availability of staff or due to the difficult financial procedures. As an archipelago and diverse country, many long-standing challenges need locally tailored and context-based solution. For example, in some places, essential newborn care is still suboptimal areas. In other places, we need to develop more centers for excellence to provide specialist neonatal care. As you see in the picture of the map that we have separated by Cs. All of these challenges require strong leaders and require sustained political leadership and specialized expertise for improving newborn area including clarify some misperception among community or newborn care, such as exclusive breastfeeding, which they are focusing on only on the milk. And also from the health provider themselves, that the very easy way to warm up the baby, they are offering incubator, which the kangaroo mother care is more suitable on that. The third acknowledge and examples about how have improvements to hospital management led to better newborn care in public and private health facility in any unique challenges across public and private sectors. The presence of leaders and champions are critical for health system, and leadership is critical at all levels for small and sick newborn, including in the labor room, on the neonatal ward, hospital management level, and administrative or policy making levels. There are many prominent champions for newborn health in Indonesia that have include health professionals such as midwife, doctors, neonatologists, pediatricians, and community health workers. Politicians, journalists, religious leaders, government officials, local leaders, parents, donors, celebrities, and other influential individuals. Unfortunately, they are all scattered and not in the integrated. These champions have been vital in promoting and facilitating policy change, raising the importance of newborn health in the country. There is an example of collaboration of related MNH professionals to give limited authority to the frontline healthcare workers in emergency, such as made a joint statement to allow trained midwife and nurse to give injection antenatal corticosteroid for premature labor and injection antibiotic under supervision for newborn with sepsis prior referral at the remote area. The third one, the last one is in the box on the left down there, examples of hospital management interventions that some specific example of hospital management intervention that have been implemented at the local level in Indonesia, that dedicated hospital director as champion leader supported by committed pediatrician and neonatologists have managed to improve health service for newborns, including strengthening referral system, utilizing IT, building capacity health providers through low dose, high frequency to maintain the skill for comprehensive emergency obstetric neonatal care in the hospitals, management and governance as well. There is short of human resource in health, for some example, in doctors in Indonesia. With the population of 245 million people, there are supposed to be 245,000 doctors in Indonesia as per WHO standard, one doctor for 1,000 population. However, currently there are only around 150,000 registered doctors available. Therefore, effort of having well-distributed human resource is still a problem for just such a long time. In the context of COVID-19 pandemic in Indonesia, it is a blessing in disguise, and innovative leadership made several tasks shifting as previously done and have been tried out newer initiatives. This include initiative for performance improvement through remote mentoring, blended learning, utilization IT for telemed conference that healthcare workers involved in newborn care have updated knowledge and the skill. There have also been several initiatives to improve use of data for decision-making, adaptive management, for example, through data dashboard for newborn resuscitation. I think that's, I can share the experience from Indonesia. Then I would like to hand over to Lucky Mangwiro to continue the experience in Malawi. Thank you very much.
Thank you so much. Just to continue from where my colleague has left, I'll give an experience for leadership and governance for Malawi. Quality of care governance experience from hospital quality improvement visit in Malawi. This report will regard from April to June 2022. Next slide. Quality improvement visits are usually done every quarter in Malawi. which are led by Ministry of Health, quality improvement directorate at both national and zonal levels. The quality improvement structures at facility level include quality improvement support team. On this list is comprised with the hospital management level, which include the DMP and including even the administrators on that case. And also there are also which are work improvement teams that are at departmental level or ward level that structured in Malawi. The QI visits, the newborn, are structured into 4 tracks, whereby there is a clinical track, management and governance track, information system, and biomed or technical track. Next slide. On the clinical track, there are representatives from Ministry of Health level, whereby at in clinical, we have representatives from Ministry of Health, from Clinical and Reproductive Health Directorate. On biomedical, we have a representative from PAM, which is Physical Asset Management Department. And on information systems, CMET is included, that is a Central Monitoring and Evaluation Directorate. And on management and governance, we have Quality Management Directorate from the ministerial level. Next slide. So there are more lessons that are learned through the quality improvement that are done in the facilities in Malawi. Mostly these facilities includes the central hospitals, the district hospitals, and also part of the SAM hospitals. So on governance, it was observed that kits are available in all the hospitals, which also there is a recommendation that we need to include the head of department in this case, since it only complies with the HMP members. And we noted that some hospitals have restructured the key system to replace the inactive heads of the department with more active members. And it was also observed that the KISS and WIP meetings are erratic and they doesn't have enough evidence to show that the KISS support the WIP. Next slide. And the WIP for the neonatal care unit are available in all the facilities. The number of members, the WIP varies from various facilities. Some are 2 to 8 members. Some WIP do not include biomed and data officers, which zonal team collected that. That is now sorted out. Some QI projects, there is a need for involvement of labor ward staff, whereby the projects are only done in the nursery ward instead of also combining with the staff from labor ward. Almost all the WIPs, they didn't have documented QI project, and mission hospitals, they're lagging behind on quality improvement knowledge compared to the government hospitals. Next slide. On setting implementation targets, some hospitals have neonatal targets that are being posted on the walls for their neonatal care unit, and hospitals now are looking to review their projects that they planned during the visit to be monitored regularly. Next slide. The zonal QI facilitators, they help in coaching the WIP on the QI processes using the facility QI and national QI guidelines that are used in Malawi. And they also recommended WIPs to meet every week and the QIS every month to review the progress of the QI project in the respective facilities. There's also some issues of blackout, which is a regular problem in Malawi due to electricity fault failure, and administrators in hospitals, they believe they are doing well since after there is blackout, at least they are able to provide support with generators. So now at least a small gen sets are there in the at all times for a backup for the nursery unit if the electricity goes off. Next slide. Thank you. That's the more lessons that are learned in Malawi during the QI visit. Over to you.
Thank you, Lucky, for your presentation. I think there is a question for Dr. Ashok Deorari in the chat, but looks like he's got disconnected. But I see that there's a hand up. Danielle, do you have a question? Did you want to say something before we ask the panelists? Are you there? Okay, looks like maybe that was by mistake. So maybe one question I can kick us off with is maybe for Pancho in Indonesia. Can you elaborate a little bit on the role of Pokjas at the district level and how they lead all of this quality improvement processes at the district level in Indonesia, which is really unique. Maybe could you elaborate a little bit on that?
Thank you very much, Gaurav. Briefly, I can say that this working group of Pokja have the strong power that they not only as an advisory, but also as a monitor of the progress of the service. So they have the advice to the local government and consists of a member of the Pokja from various stakeholders responsible for the quality care in the public there. So politically sound, they have also the power authorized by the local government. Thank you. I hope this can.
Thank you, Pancho. Yes. Maybe one question for Lucky. You know, in your slide decks in your slide deck, you mentioned that mission hospitals or non-governmental hospitals, they seem to be behind on QI processes compared to public sector facilities. Can you talk about why that is? I was just, I think that's quite interesting how this, how the adoption of QI or how buy-in for this initiatives is different across different settings. Can you talk a little bit about that?
Thank you so much. Mostly, since the QI visits are read by the Quality Management Directorate, which works under Ministry of Health, mostly they work with government hospitals rather than mission hospitals. So mostly, like NIST is working with almost 8 facilities that are mission facilities, not all the facilities. So it seems more information or more knowledge is applied to government hospitals rather than mission hospitals. So that is the point that we need to work on, so that also the mission hospitals, they also have more knowledge on quality improvement.
Okay, thank you, Lucky. So I saw that there was a question in the chat from React Asia Pacific. Unfortunately, looks like Ashok got disconnected, but the question was, could you please elaborate on the M&E component of the activities mentioned in India, and maybe also the key supporting factors identified during implementation? I think this is, so India has a real-time information system at all NICUs that you can get real-time information on all admissions that happen, all of the neonatal outcomes, but also like Dr. Ashok was saying, there is high-level commitment from the local government. There are national initiatives for quality improvement in the labor rooms, in the neonatal units. SOPs exist. So I think it is a multifaceted process, and there is guided by data for decision making. They're also doing point of care quality improvement, so setting improvement targets, aims, working to all facilities, monitoring a common set of indicators, and just implementing these QI cycles. He got disconnected, but I think that is the short answer to that question. So we have about 5 minutes left. Maybe just briefly, one last question to you, to all the panelists is, what do you think is one lesson from COVID-19 and the work in quality improvement that you will take forward in your own work? What has COVID taught you for the quality improvement work that we're doing that will now be taken ahead as a part of the QI work going on in Malawi and in Indonesia, maybe. Do you want to start, Dr. Pancho, or do you want to talk about the Indonesia experience first, and then we'll ask Lucky to weigh in?
Yeah, thank you very much, Gaurav. Actually, this really give us a lesson that basically our president also announced that we are not ready. The hospital is not ready to receive these cases. So this is caught by surprise. And this lesson learned causes that the government take a very serious matter, that all out with the funding. But this as a lesson that in the future we have to prepare this better for this kind of thing. And we put up some initiative which is more on the vaccination, that this one is more better than curative. Thank you. Over.
I think you did mention some blended learning and digital health interventions, which I think are also going ahead in Indonesia. One lesson learned from COVID. Maybe Lucky, same question to you. Any thoughts on lessons learned from COVID that you're taking ahead in your work?
Thank you so much. On that, indeed, COVID-19 pandemic was discussed to us as well in Malawi. So in preparedness for COVID-19, we have learned that we can also do better in quality improvement for the neonate. We can utilize even the chance of using digital, like digital health, which can also, with the congestion in the world, most people were failing to be available in the hospitals. So we can also provide neonatal care digitally, and neonates will also be assisted in that way. So I think digital health can also assist in providing neonatal care. That is the lesson that we have also learned during the COVID-19 pandemic.
Thank you. Thank you, Lucky. So maybe before we wrap up, anyone from the audience have any burning questions or something that they want to ask? Any last minute questions? If you could just raise your hand, we will give you the opportunity to ask your question to the panelists. I don't see any hands. Okay, so if there are no questions, I think we will close this meeting, and I would like to turn it back to Professor Tim Powell-Jackson to give a few summary remarks, and thank you all once again for attending.
Thank you very much for attending, and thanks to our speakers. We heard some really interesting different perspectives on this issue of leadership, governance, and management. Ashok talked about the importance of governance and leadership through the different levels of the system, a great emphasis on data and the importance of good governance in terms of having a stable policy environment. But there does remain to be a shift in the mindset of bureaucrats. Pancho talked a lot about champions in Indonesia and the high-level political commitment there, the influence of these district working groups, and again, the importance of reliable data systems, but particularly at the point of care. And then it was interesting, Pancho, you brought in also the challenges of the private sector. And I think many of those challenges ring true to us working in different countries around issues around incentives, regulation, and how clinical governance is managed by lots of different actors. And then Lucky spoke specifically around the experiences of QI visits in Malawi and how those QI visits are building on the sort of institutional structures already there in hospitals, these so-called KIST and WIT committees, and how the government, Ministry of Health in Malawi, are trying to address some of the challenges related to the effective functioning of these hospital structures. So thanks very much to the speakers. Thanks to Gaurav. Thanks to Mita for organizing, and a big thank you to all those who've attended. As Zoe has said in the chat, if you've got any further questions, please email to the Newborn Toolkit email address as written in the chat. So thank you very much, and enjoy the rest of your day.